Yes, sir.
Yeah,
Yes.
Is it there?
Yes,
yeah,
sir.
Yeah,
okay.
yeah.
You see, we just had very nice talks by Vastav and the other person. Believe
Kashyap.
me, future is not going to be the same. We, for I think 1 or 2 years, all the practices are going to take a back seat, and we have to redefine. And there has to be a new calibration and new normal also. There's always a debate between life versus livelihood. See, the nation today, Modi ji and all are planning to save life, but what about livelihood, which is lacking? But I think in some time in the a week or so, as Mahipal was saying, we have to start slowly. But my priorities from surgery point of view would be still slow, priority to one-eyed and more emergent patients. Obviously, observe all the mandated precautions which you all know, sanitation, mask, and etc. But stagger your surgeries. No crowding in the OP. Prefer topical versus local versus GA. And PPP is, I think, for ophthalmology is not a must. You see, PPP is quite cumbersome and it makes your movements very cumbersome movements. Only if there is a definitive COVID patient or a suspect or some messy surgery like DCR and all, then maybe PPP may be required. But full PPP in a routine cataract or even VR surgery, I don't think so is a must. Extra precautions we should all take as we do in HIV patients, like double gloves, etc. But because the basic aim always is to reduce risk, not only to yourself, to your staff, which is very, very important, and to your patients and attendants also. There's a lot of controversy what all investigations to be done, because a lot of people, in fact, our anesthetists also says COVID screening is a must for all. And I know of a lot of hospitals, which includes Apollo as well as Gangaram now, which says COVID for all the patients. But I thought pre-op X-ray chest or CT chest may be better. And always have to have a high-risk consent. High-risk consent is a must, which includes regarding potential for that patient can become COVID positive. But believe me, negative report does not rule out COVID, as happened in Indore. There were 2 negative reports. Again, the patient had a positive report and ultimately died. I thought COVID screening test report does make sense for GA patients for longer surgeries or patients with diabetes or their immune status comorbidities is there. Further, attendance is a strict no, and they can easily wait in the car. The other thing which I thought is seniors may have to work more, and every day some extra hours will have to be put and work even on holidays. And I think all of us should volunteer about the deductions and deferred payments or ESOPs. The other thing is, for YOC point of view, bedside teaching may suffer. The surgical hand-ons also will take a back seat. Can be compensated by webinars, as AIS is doing. The role of telemedicine is bound to increase. I'm happy that AIS already has done a lot of inroads into this. This is especially not for new patients, but follow-up patients. And I personally believe this should be a paid practice. Otherwise, you will be bombarded with questions. It has to be a paid, so that you have to learn how to open that portal for payment. We all know it has been legalized lately, but be careful. Although legalized, but it still comes under CPA. Patients can still sue you. So all of us have to learn this art of and have a payment platform also. So just to conclude, keywords are start slowly, but definitively. Prioritize, take extra precautions. COVID testing, I think, will become a must for some time at least. Fast and safe surgery has to be the norm for some time. And more working hours we have to be prepared for, and also be prepared for salary cuts and layoffs. And telemedicine has a good future.